Hello, everyone. My name is Saad Usmani. I'm the chief of the Myeloma service at Memorial Sloan Kettering Cancer Center, and I'll be talking about the bispecifics and their use in relapse refractory multiple myeloma. I would like to, highlight, with some cases as I go through my presentation. Um, One thing that we are recognizing about the immune therapy landscape in myeloma um, is we've moved on from the conventional chemotherapy drugs and small molecules to these immune therapeutics. And with the responses and durability of response we're seeing with these therapies in myeloma, our collective aim is starting to gear towards curing a subset of myeloma patients. So in the past, we never talked about this, but with some of the data that I'll be sharing today, I just wanted to share my measured enthusiasm that we are going to be moving in that direction. So it's an exciting time to be a myeloma doc, myeloma researcher, myeloma investigator. So let's start with the first patient case. We have a 69-year-old female, originally diagnosed with revised ISS stage 2 disease, IgG kappa myeloma, now with relapse refractory disease with gain 1q21, being treated with a GPRC5D targeting bispecific antibody on a clinical trial. Patient has had 5 prior lines of treatment, including proteasome inhibitors, immunomodulatory drugs, anti-C38 monoclonal antibody, SLAMF7 targeting monoclonal antibody, as well as cyclophosphamide. The patient had originally deferred autologous stem cell transplant. In terms of comorbidities, the patient has COPD, at home oxygen of 2 to 3 liters, and that's why the transplant was deferred. Has associated pulmonary hypertension as well as hypertension and obesity. Baseline BMI prior to starting GPRC5D bispecific antibody was 34. The patient gets enrolled on the clinical trial and tolerates the step-up dosing, but does develop grade 1 cytokine release syndrome. And, if some of you recall the grading for CRS, this is a fever that gets managed with supportive care and acetaminophen. During cycle 2, the patient starts to note mild nausea and decreased appetite, as well as taste alterations. However, the patient continues to respond well, and within 3 months achieves MRD negativity and a complete response. The GI workup that's been done is negative for any infections or other abnormalities. Symptoms, however, gradually worsen, leading to an approximately 20% decrease in body weight after about 5 months of therapy. So at this point, we have tried antiemetic agents without significant relief. This includes, ondansetron, prochlorperazine, lorazepam, as well as metoclopramide. Patient tries dronabinol, which initially helps with this nausea and dysgeusia, but then there is limited improvement in weight. Also tried on sucralfate. Now, what happens with the bispecific antibody is there is dose reduction, and then there's a transition from weekly to every other week dosing. And that actually helps improve the patient's symptoms. Patient starts to gain the weight back. The lowest BMI that the patient got to was 24, and now the latest BMI, the patient is back to around 31. So patient now remains on treatment for about 18 months and remains in an MRD negative CR.
So before you go on to the next case, I'm just kind of curious. I'm assuming this GI symptomatology is directly from the agent?
Yes,
is that a reported side effect?
Yes, and we'll be covering some of that information later in the presentation. But this appears to be a GPRC5D target issue. So this is an on-target off-tumor side effect. So GPRC5D is overexpressed in the GI tract.
Very interesting. So I assume you don't see this kind of GI problem with the BCMA bispecifics?
No, we do not see that with BCMAs.
One other question before you keep going here, just out of curiosity, because she does seem like she's got pretty significant comorbidities. Would she have been a candidate for CAR T?
That's an interesting question. I think with the comorbidities, she may not have been deemed a CAR T candidate. COPD was the key decision maker there.
Right.
So moving on to the second case, we have now a 57-year-old gentleman, originally revised as ISS stage 2 disease with IgA kappa isotype, now with relapse refractory disease. And this patient is on the FcRH5 bispecific antibody. Originally diagnosed as standard risk cytogenetics, in May of 2017, but since then, patient has had 6 prior lines of treatment, and here again, proteasome inhibitors, immunomodulatory drugs, anti-CD38 monoclonal antibody exposure, cyclophosphamide, as well as autologous stem cell transplant. Interestingly, this patient has history of significant, cardiac disease, so hypertension, has had a cabbage, has obesity, has residual peripheral neuropathy from prior bortezomib, and also has, hyperlipidemia as well as NAFLD. The patient does have significant back pain, chest wall pain, and right shoulder pain at the time of this particular relapse. The PET-CT is showing an anterior mediastinal mass, which is extramedullary in nature, as well as multiple lytic bone lesions that are FDG avid. So quite significant disease burden here. The patient gets a salvage auto based on labs and how quickly they were progressing, but they go on and receive palliative RT to this anterior mediastinal mass and then get enrolled on the bispecific antibody study. They have grade 1 CRS during step-up dosing. The patient starts develop bone pain involving the shoulder, chest wall, back pain with each treatment dose that would resolve after 24 to 48 hours with initial cycle. So I can talk a little bit about that, but we have observed that interesting phenomenon of the pain worsening in areas of disease with bispecific antibody use, and typically tends to portend responses. So in cycle 2, the patient starts to have increased numbness and tingling in the feet, which did not affect the activities of the daily living as well as gait. The patient does have prior history of that sensitive neuropathy due to bortezomib, which had improved after bortezomib had been discontinued, but there was still some residual symptomatology. Now patient starts to develop burning sensation in his feet, especially worse at night, with subsequent cycles of this FcRH5 bispecific antibody. So initially the pain was, grade 1, and now with the burning sensation, patient starts on gabapentin with some relief. But that sensory neuropathy, even at this point, besides the nighttime symptoms during the day, does not affect the activities of daily life. So the symptoms remain under control now on gabapentin. The night symptoms have also improved. The patient is now in a VGPR on a clinical trial with this FcRH5 bispecific antibody.
So just a question about the pain that occurred in the tumor sites. Is that seen with all the bispecifics, despite, sort of their target? And do you see it with CAR T?
Yes, so we do see it with bispecifics. We have seen it some with CAR T cell therapy. And we've seen, that kind of discomfort happen, regardless of what the target is with the bispecifics. Doesn't happen with every patient, but we do observe this.
That's really interesting. Any other form of myeloma therapy where you see that?
No, we have not observed, that kind of effect with other therapies. I do recall that at a point when we were looking at checkpoint inhibition in myeloma, that we saw some similar kind of observations in responding patients with nivolumab as well as pembrolizumab on clinical trials.
Wow, that is really interesting. Please continue.
So moving on to case number 3. So we now have a 49-year-old patient originally diagnosed with stage Duricelin stage 3 IgG kappa myeloma, now with relapsed refractory disease on a BCMA bispecific antibody. Originally diagnosed, more than 10 years ago. Patient did have hyperdiploidy kind of disease later on with amplification 1q21, has had 10 prior lines of treatment, including PIs, IMiDs, anti-CD38 monoclonal antibodies, cyclophosphamide tandem transplants, also had a salvage auto, and a BCMA-directed CAR T cell therapy. Comorbidities include hypertension, hypothyroidism, and asthma. So this patient was very young. They were in their 30s late 30s when they were diagnosed, and now they've had 10 prior lines of treatment. So the BCMA-directed CAR T cell therapy, had flu-cy conditioning. There was initial response with PR, but then there was disease progression after 5 months. So patient got enrolled on the BCMA bispecific antibody, again, had grade 1 CRS, otherwise with the subsequent dosing, no other side effects were seen. Now, during cycle 3, the patient went on to develop nasal congestion, post-nasal drip, intermittent chills, and diffuse myalgias. Interestingly, here the respiratory viral panel was positive for adenovirus. Chest X-ray was negative for infiltrates. The adenovirus PCR that was quantitative demonstrated viremia. Patient also had other systemic symptoms such as diarrhea with cramping abdominal pain. Stool 2 was positive for adenovirus. PET-CT that was obtained to reassess response given the history of extramedullary disease showed no abnormal uptake or infiltrates in the lungs. And on labs, patient was seen to have hypogammaglobulinemia. So patient had persistent sinusitis symptoms with congestion, ear pressure, headaches, post-nasal drip despite supportive care measures. The patient was seen by ID as well as ENT. The respiratory symptoms initially managed with supportive care, but they continued to be an issue. Antibiotics were introduced for the possibility of a superimposed bacterial sinusitis. Eventually, the patient underwent endoscopic sinus surgery for chronic sinusitis, and then the symptoms started to improve. The patient was also started with IVIG every 4 to 6 weeks for the hypogammaglobulinemia. And that intervention started to improve the adenovirus PCR. Viral titers went down, the diarrhea became better, and the use of Imodium was used on a PRN basis for that symptom. So the viremia eventually cleared. The respiratory symptoms lasted for another 4 to 6 weeks. Diarrhea resolved after about 5 days of clearing the viremia, and the patient was able to restart BCMA bispecific. However, the patient progressed after cycle 5. So if you recall, they had stopped after cycle 3, and then there was this break of about 2 months. They got 2 additional cycles and then came off study because of disease progression. So, here this case highlights the fact that you are able to sequence different BCMA therapies, CAR Ts and bispecifics, but one has to be very wary of atypical kind of viral infections that can happen and can affect different organ systems.
Just out of curiosity, do you see adenovirus like this just from myeloma?
No, this is very atypical. So, with some of these immunotherapies, we're seeing infections that you would see in allogenic stem cell transplant setting. So not just with adenovirus, even with CMV, viremias and CMV, gastroenteritis or pneumonitis, has been reported with some of these BCMA-directed immunotherapeutics.
So both CAR T and bispecifics?
Yes.
Interesting. And I guess there's no specific antiviral you can use for adenovirus?
No, it's largely supportive care and IVIG use.
Interesting. Please continue.
All right. With these cases in mind, I wanted to summarize the bispecific antibody data in multiple myeloma. So, bispecific antibodies are a big umbrella under which we have many different platforms. Depending on the parts of the monoclonal antibody structure that has been utilized to create these constructs, that's what gives these bispecifics a different name. So a BiTE or a bispecific T cell engager is only smaller variable region chunks of of a full antibody that have been utilized to create that structure. Then others would have different portions of different full antibodies being created together. So you can see there are many different constructs, but the way that they work is the same. One part of the structure recognizes the surface marker on the cancer cell, the other part recognizes the surface marker on the innate cell. So in this case, for T cells, it's CD3. And then that's how the T cells go on and kill the cancer cells. So what are the pros and cons?
Just kind of curious on that point before you go on. At least in solid tumors, I've heard about a number of bispecifics that don't have a CD3, and they target another part of the target. Is there anything like that in myeloma? Like, I think there's one for in lung cancer. I think it's c-Met or something. But again, it's not a CD3, and there's one on HER2. It hits two different parts of HER2. So do you have anything like that to say for BCMA or myeloma?
We don't have the data in the public domain yet, but those kind of constructs are called trispecifics. So they may be binding to two different kinds of surface antigens on the myeloma cell. But those are not in the public domain yet. They're still in clinical trials.
And they still have a CD3 arm, though?
They do. They do.
All right, please continue.
So when we talk about the pros and cons on of bispecifics, I think the pros are fairly straightforward. These are off-the-shelf therapies, low-grade cytokine release syndrome for most part, for majority of patients, very low incidence of neurotoxicity, so making this more amenable in the community setting. We already have different targets: BCMA, GPRC5D, and FCRH5. Unlike the CARs, where we're still kind of testing, validating the utility of GPRC5D CARs in clinical trials, we already have quite advanced data with these different targets in clinical trials with bispecifics, and that will help us combine these different bispecifics with other mechanisms of actions, compared to, say, CAR T cell therapies. So, with that in mind, I'm going to come back to the potential cons, which I've tried to highlight a little bit in, the three cases that I've presented. Teclistamab was the first EMA FDA approved bispecific antibody in multiple myeloma, showing us very impressive overall response rates and durability of response. But we now have many different constructs that are in clinical development. So the teclistamab construct is subcutaneous. Currently, it's approved to be given on a weekly basis. But you can see from the routes of administration from the others, that the dosing and frequency is a little bit different for each of these constructs. And it's really predicated by their affinity for BCMA as well as the overall structure. If we look at the response or the patient population, that went on each of these experiences, we see a high proportion of patients with triple class refractory disease. The important part, as I highlighted, the CRS is primarily grade 1 and 2. And there are probably going to be differences in the proportion of patients who get CRS. However, neurotoxicity, as you can see, it's very low, and you don't see high-grade neurotoxicity much at all with these BCMA-directed bispecifics, and that signal is better from the safety perspective compared to the CAR T cell therapies. And then in terms of the responses, you see majority of patients getting to well over 60% responses. And teclistamab data set is the most mature data set. So we already have median PFS and duration of response that's been reported. So 11.3 months of median PFS, and the duration of response median being 18.4 months. So for this advanced patient population, this is quite an impressive data set. I wouldn't be surprised if we get similar kind of data for the other bispecifics, because the responses are somewhat in the same kind of a range. What about the non-BCMA bispecific antibodies? You can see here, telketamab, which is a GPRC5D directed bispecific, has the most mature data, and this might become our first GPRC5D directed bispecific that gets regulatory approval. But we also have data from forimtamig, which is a different construct. Both of these are subcutaneous, but forimtamig actually has two binding domains for GPRC5D. And then the last construct that's further along in clinical development is cevostamab, which targets FcRH5 along with CD3. However, that bispecific antibody is given IV, and it's given on a 3-week basis. If we look at, again, the routes of administration, I kind of highlighted this, that for the GPRC5D ones, it's subcutaneous, but the frequency is a little different. So with telketamab, we both have a lower weekly dose and a higher Q2-week dose that's been examined. And the responses and durability of response appear to be, somewhere in the same range for both. And then, with the forimtamig construct, the dose is given every 2 weeks. The CRS and the neurotoxicity patterns are a little bit different. So with GPRC5D, we do see, the low-grade CRS making up the bulk. However, we do see a higher incidence of neurotoxicity with GPRC5D as well as with FcRH5 compared to the BCMA targeting bispecific. So this is a little bit of a different pattern. However, the good news is grade 3 or higher toxicity is fairly low. It's about 1.6 to 1.8% with telketamab, 0.6% with forimtamig, same number with cevostamab. Overall response rates, and the depth of response and PFS has been reported with telketamab, as well as with cevostamab. We have duration of response that's been reported. But it's good to see that we have activity as well as durability of response, beyond BCMA as a target with these bispecifics. The elephant in the room is always the infection risk, which appears to be, a higher signal in BCMA-directed bispecifics than in non-BCMA directed bispecifics. And that, I think, is going to be something that we have to figure out as a community. And I would love to get into that as we get into the discussion portion of the program. So the one big con is, you've seen the bispecific response rates being quite high, but not every patient is responding to bispecifics. And there are different reasons for that. So some are construct related, others are related to how healthy the T cells are in a given patient. Then there are tumor related factors as well. How high is the tumor burden? Has there been diminished or loss of antigen on the surface of the myeloma cells? Do the patients have more proliferative disease with high risk cytogenetic features or extramedullary myeloma? And then we also have to pay attention to the immune suppressor cells that are present either in the bone marrow microenvironment or in case of extramedullary disease in the organ tissue where those extramedullary myeloma exist. So there are strategies that are being studied right now, combining CD38 monoclonal antibodies with bispecifics, IMiD cell mods, as well as checkpoint inhibitors being explored. So we are engaged in those in clinical trials, and we'll probably have data. I think the infection risk is related to this continuous therapy model, where patients have a higher risk of infection because of hypogammaglobulinemia. Therefore, we are utilizing IVIG administration for those patients. And then in terms of prophylaxis, VZV and PJB prophylaxis is something that we are utilizing for patients, as standard of care. And there are international myeloma working group guidelines that are being developed that will, help facilitate, how to manage these patients, for primary as well as secondary prevention of infections. And the last piece, I want to share as an example is the case for fixed duration treatment with bispecific. So this is one of my myeloma patients who was on the original teclistamab study, and they came off of treatment with teclistamab due to recurrent URIs. And their last dose of teclistamab was the end of January of 2020, and they remained off of therapy for almost 3 years, with MRD negative status. And so, the case I wanted to make here is you can get durable responses with bispecifics without compromising, the infection risk issue. So we might be heading into, a an evaluation phase in clinical trials of using these bispecifics in a response adaptive manner, and then maybe providing more dose interruption. So the other important thing that I do want to highlight is the logistic challenge of for the community at large of managing these patients during the first cycle of treatment, and picking out patients who can be treated in the outpatient setting altogether instead of requiring that initial closer hospital and hospital monitoring. So I just want to give an example of how we manage that at MSK. After the initial FDA approval and getting the P&T committees to sign off on drug use, we initially treated patients with 5 day of inpatient monitoring, with between November and March, looking at our safety data in our population to see, are we seeing the same pattern of low grade CRS, and low rates of neurotoxicity that was reported in clinical trials? And the answer was yes. So then we started to have patients go through an early discharge after step up dosing. And then early intervention with tocilizumab if patients had persistent fevers to reduce the likelihood of their hospitalization stay. And now we've started to do all outpatient dosing for select group of patients. And so, this is where, the last step of response adaptive reduction in dose frequency, instead of the weekly dosing with teclistamab, we are going to every 2 or every 4 week dosing after patients have gotten to a VGPR or better for at least 2 cycles of treatment. And so, we'll have more data to share, how this experience looks like with the community colleagues. But, this is where I think, we're going to be doing things a little bit different, in trying to manage that infection risk long term. So with that, I'm just going to acknowledge, the myeloma service colleagues, and I'll be happy to take any questions.
The intermittent treatment sounds interesting. Kind of reminds me, I don't know if you're familiar with intermittent androgen deprivation and prostate cancer, where they treat, and people have PSA only disease, they treat till the PSA goes down, then they stop the treatment. Is that sort of what you're talking about doing?
So what we're thinking about doing is, if someone has had a good response, VGPR or better, to teclistamab, to start giving less frequent dosing. If they are having issues with the recurrent infections, then just withhold treatment for 2 or 3 months, continue to monitor disease, and re-challenge them, with the BCMA bispecific if you start seeing disease activity. I think the way that we use bispecifics will evolve over time. We know they work, but and we also know that loss of BCMA is not the primary cause of resistance. So BCMA is one of those targets that gets, that doesn't go away. Mutations are very infrequent.
So again, just to kind of clarify, when you do that, have you, I don't know, have you actually done that where you just stopped it and people doing well? And when you do that, are you usually able to recapture them when you restart?
I think we're just starting to do that now, because the drug just got approved back in the end of October of 2022. But that case that I demonstrated, or shared with you, that's one of my Majestic-1 patients. So that's one of the patients who was on the trial that led to the FDA approval. You know, patient being MRD negative for almost 3 years, without the disease coming back, demonstrates to you that this is doable. And my other colleagues have similar kind of examples. But Dr. Love, you'll have to ask this question to me a year from now, and I'll be able to share some of those experiences. But what we've seen from patients who get CAR T cell therapy and have a disease relapse, you are able to capture response by giving them BCMA bispecifics.